Hello, I'm George Cheng Chen. I'd like to welcome you to my talk on an anabolic approach to joint health. I'd like to take a moment to thank my friends, Sadiq Bayani and Amar Salti, for inviting me to be a part of their prestigious meeting. I wish I could have made it to Dubai and be a part of this Gulf Pain School Pain Expo 2022. Hopefully, though, I will be able to make it again in the future and see you all soon. I'm currently the Director for Pain Medicine, as well as the Director for Physical Medicine and Rehabilitation at the Ventura County Medical Center, an UCLA affiliate. I also have a private practice in Irvine, California, called the GCC Institute, where we practice regenerative medicine and medical aesthetics. My disclosures are that I am a speaker for Apex Biologics, a company that produces medical supplies related to regenerative medicine. My practice consists of traditional bread and butter near-axial procedures, as well as peripheral nerve blocks and peripheral musculoskeletal injections. I prefer to focus on anabolic options such as regenerative medicine and hydrodissection of nerves with pro-anabolic compounds such as platelet-rich plasma or bone marrow aspirate. With that said, I'm going to delve into discussing joint disease, because joint disease really is the primary cause of disability throughout the world. Thus, when you think of a joint, what do you think makes up the joint? Is it just the bone, the cartilage? What else is there? Well, there are many things that actually make up the joint, and it is a complex structure that is found throughout your body. The tendons, the ligaments, the muscles, the fascia, the capsule, the synovium, even the fat has been found to be biologically active, whether or not there's vasculature there, as well as the end plates and the subchondral bone and the bone marrow underneath. These are all actually biologically active structures that make up joint health. As previously mentioned, arthritis is the most common type of joint disease and is the leading cause of chronic disability in older adults throughout the world. Although classically described as being a mechanical process, breakdown of joints actually is much more complex than that, and there's both a mechanical as well as a biochemical processes that underlie this disease. Here's a summary slide that shows what is going on in an arthritic joint. When we have breakdown of the cartilage, the chondrocytes, which are the cells of the cartilage, will break down into tissue-degraded products. These products that are released into the joint cavity will cause a response by the synovial membrane, which is biologically active. This synovial membrane results in inflammatory proteins that induce a feed-forward mechanism that releases matrix metalloproteinases that will further break down the cartilage. This results in a feed-forward mechanism that causes eventual wearing away of the joint. In addition, this is one reason why we have an explanation for why we have return of synovial fluid despite frequent aspiration. One other thing that you should keep in note is that within the bone marrow and the subchondral bone, we do have mesenchymal stem cells. And these are the cells that are attempting to replace the chondrocytes and the joint bone at the edge of the articular surface. These classic stages of knee arthritis, as diagnosed by plain film, are actually a little bit crude, because we see that most patients, or many patients, start to develop pain while their x-rays are still relatively unremarkable. This slide depicts the natural progression of arthritic joint disease. On this left-hand side, we have what is the pearly iridescent edge of the articular joint, and that pearly iridescent border is the articular cartilage. That, in this cartoon on the right-hand side, corresponds to this purplish colored area. Now, as we progress, we not only have destruction of the calcified cartilage, or non-calcified cartilage, we also have subchondral microdamage. The subchondral microdamage can progress to become subchondral cysts with destruction of the overlying cartilage. You'll notice in this image that we can utilize ultrasound to evaluate the distal femur and the health of the joint. Here we have the anechoic articular cartilage, which is almost universally symmetric until we get to this point on the medial femoral condyle, where it has been eroded away and been replaced by a large significant osteophyte. We can also use this ultrasound to grade the erosion or the loss of the articular cartilage over time. Under histologic dissection, what we see is that the cartilage is made up of different types of cells. We have these isogenous cell groups. These are chondroblasts that have divided and created what are called cell nests. These cell nests become mature and are called chondroblasts, and they secrete this pink area in between, which is the extracellular matrix. This extracellular matrix is the connective tissue that holds all of this together and is slowly eroded away each day as you take a step and create wear and tear on your articular joints. Now, where can we find stem cells? We can find them certainly in the articular cartilage. We can actually also find them within the subchondral bone, and indeed, even within the fat within your joint. And this is an important slide just to reinforce the idea that your body is constantly trying to repair itself. Historically, it was believed that there was no stem cells within the heart as well as the central nervous system. And even as recent as within the last 10-15 years, it was not until then that these things were discovered in those tissue structures. Coming back to joint disease then, let's talk about our current treatment paradigms. What do we recommend for our patients? We recommend them to try utilizing some type of bracing. This is like an exoskeleton to take pressure off of the joint, but they are typically cumbersome and can be expensive, and they do not fully take off that weight. What else do we explain to patients to do? We explain to them to try non-steroidals, which obviously can be harmful to the body. We tell them to lose weight, which is challenging, and we send them to physical therapy. If they have failed these things, options include corticosteroid injections, or even genicular nerve blocks and radiofrequency ablation. What is now very popular is peripheral nerve stimulation or even dorsal root ganglion stimulation. If all of these options fail, patients may undergo total knee arthroplasty. If you're not aware, studies show that even up to 40% of patients that undergo total knee arthroplasty have persistent knee pain afterwards. So what do you do for these patients? Well, we undergo radiofrequency ablation or PNS and DRG stimulation again. If you're listening to this and this describes some of your frustrations with our current treatment paradigms, then I think regenerative medicine is a good option for you and your patients. Let's discuss some of the injectates that we use. There are many papers that demonstrate that local anesthetics and corticosteroids are harmful to soft tissues. They are harmful to the tenocytes in your tendons, the chondrocytes and chondroblasts in your cartilage. They're harmful to the ligaments. They're harmful to your disc. They're harmful to the MSCs inside your disc, as well as the MSCs throughout all the other soft tissues. To expand upon that, people have a tendency to forget that corticosteroids are actually hormones. These are biologically active. They increase insulin resistance, they cause atrophy of muscles, skin, they can induce mania or depression, and reduce bone mineral density. When they are injected into a tendon, this actually leads to cell death and tendon atrophy by inducing cellular apoptosis. Corticosteroids inhibit collagen synthesis and decrease load to failure. This perhaps is a great representation of the combined deleterious effects of local anesthetics and corticosteroids, because this is a very common concoction that people will use, lidocaine and triamcinolone. Now, this is a basic science paper where they took tendon cells, tenocytes, and they plated them. You'll notice in this control group that you have the normal cells up here. They have the normal morphology right there. When you give these cells triamcinolone or expose them to triamcinolone, you'll notice that many of the cells die off and they become vacuous or translucent. If you combine them with local anesthetic, 1% lidocaine, the same effect. And when you do all of them together, there's a synergistic effect where all the cells or most of the cells are going to be dying off. Shifting gears, I'd like to talk about hyaluronic acid. Hyaluronic acid is a complex sugar chain that binds to water. Now, it's only been FDA approved for treatment of knee arthritis, not because they didn't try and go after other indications, but because it was only shown to be beneficial in knees. There have been multiple studies that compared hyaluronic acid injections to both intra-articular corticosteroids, physical therapy, nonsteroidals, and other matters of conservative care. And in general, it is deemed superior for functional and pain scores over intra-articular corticosteroids. Now, when we explain to patients how does hyaluronic acid work, typically people will say something like, oh, it's a lubricant for your joint. Now, they might be true, but there are other benefits, including the idea that it's non-deleterious, meaning it's not going to be harmful to the cells of your joint. Indeed, the hyaluronic acid have also been shown to increase anabolic biomarkers and increase GAG. Now that said, now that we're 24 minutes into my talk, we're going to be talking briefly about platelet-rich plasma, and I'd just like to point out that not all PRP is the same. You'll notice that there's many formulations that are out there. These tubes on the left draw very, very minimal blood. Importantly, they are probably not designed or cleared in their country for utilization to be reimplanted into a human body. This system is what I utilize on the right-hand side. You'll notice that there's an extensive buffy coat here, and that is both the platelets as well as the white blood cells. Now, if we're saying that hyaluronic acid is essentially the gold standard for many physicians prior to sending a patient to see the orthopedic surgeon to consider total knee arthroplasty, what has been looked at when comparing the efficacy of PRP versus HA? And we looked at this question and we identified multiple studies at the time when this was written in 2017, 12 studies comparing efficacy between PRP and HA. And at the time, we found 10 prospective RCTs and 2 retrospective studies. And PRP was considered superior in 11 of these studies and non-inferior in 1 of them. I really like this study, published in 2014. Now, what they did is that they took synovium and cartilage that was harvested from patients with diseased knees. These are patients that were undergoing total knee arthroplasty. And they co-cultured this cartilage and synovium with PRP or HA. The findings that they were looking for were pro-inflammatory catabolic markers such as TNF-alpha, IL-6, and IL-1 beta, as well as matrix metalloproteinases, which break down collagen. Now, the pro-anabolic factors that they were looking at on this right side include hyaluron synthase, which creates hyaluronic acid, as well as collagen type 1, collagen type 2, and aggrecan. What these authors found was that both PRP and HA treatments for the diseased joints resulted in decreased catabolic markers, that the PRP treatment resulted in a significant reduction of matrix metalloproteinases, as well as an increase in hyaluron synthase expression in the synoviocytes as compared to HA alone. The subchondral bone has become a hot topic in regenerative medicine. Now, this has been recognized to become the mediator of bone health, and it is analogous to the vertebral end plate. The cartilage is avascular, similar to the disc, and the association with the vascularized subchondral bone keeps the cartilage nourished through diffusion. Recognizing that the subchondral bone is the mediator for bone and joint health, people have started introducing injectates directly into the subchondral bone in an attempt to revitalize the health of the entire joint. Before you ever develop bone-on-bone OA, we have to recognize that there's going to be likelihood of some type of meniscal injury. The menisci are like bumper stops that are shock absorbers within the joint. We're going to briefly discuss their vasculature and how they may be able to heal themselves. To briefly review meniscus anatomy, you should be familiar with the idea that the meniscus has a white zone that is essentially avascular and a red zone that does have a decent vascular supply. This is important because it has implications for the natural healing or capacity to heal for the meniscus, such that this area here, the red zone that has a vascular supply, has a much better capacity for innate healing. Under ultrasound, we can evaluate the medial and lateral menisci, at least see the outside portions of it. Now what we have here is the distal end of the femur, the proximal and the tibia, and we have this nice anechoic cartilage that underlies or within this joint. This hyperechoic salt and pepper shaped structure that looks triangular is a cross section of our medial meniscus. Overlying this, we have the tight fibular pattern of a tightly adherent medial collateral ligament as it runs back and forth. This patient has significant medial meniscus disruption. You notice that the MRI on this top left shows a pretty significant disruption of the medial meniscus, and this corresponds to the fissure that we see down here under ultrasound. There's also disruption of the fibers that extend proximally as well as distally that attach it and affirm it or affix it firmly to the ends of the femur and tibia. You also notice that there's edema that is present running through the layers of his MCL. Now, this is actually my knee, and I have treated it multiple times with various products, including platelet-rich plasma, and I treated this myself with intrameniscus and intraligamentous platelet-rich plasma. This is my meniscus that approximately 3 weeks after that injection. You'll notice how significantly different this looks compared to the last image. I'd like to move on to the second part of this talk, which is regarding the health of tendons and tendinopathy. This cartoon shows what happens to a tendon when it goes from a normal to an abnormal state. The normal tendon is a tightly bound bundle of collagen that transmit vectors of forces for the most part in one direction. When you start to become pathologic, you have a few things that happen. You have neovascularity, where blood vessels may grow into this. You also have growth into it of C fibers, which help remind you that it's painful. And you also have increased cellularity. You have loss of the normal fibular pattern of the tendon fibrils, and you have them in disarray. There's also increased matrix proteins, which actually reduce the structural integrity of the tendon, and it's described as mucinous changes, like mucoid changes, mucinous changes by the pathologist and the radiologist. Here's the tendon under micrograph. You'll notice that for the most part in this normal tendon, these tendon fibrils run very much parallel to each other in parallel bundles, going back and forth. And here is an example of the normal supraspinatus tendon as it inserts into the periosteum. You'll notice that there's these anchoring fibers that reach very far into the bone to give it structural integrity. This is what it looks like when you have abnormal tendon in tendinopathy. You'll notice that you no longer have the long tendon fibrils that are parallel to each other. You actually have this increased cellularity, and you have that loss of the fibular pattern. On this image on the right hand side, you'll notice that we have vacuoles or tears within the tendon, as well as blood vessels that represent neovascularity. These image findings correspond to MRI. The normal morphology for the Achilles tendon is for it to come off the calcaneus and start to taper off as it goes proximal. Now, the normal area that typically has injury is what's called the avascular zone, approximately 2 to 7 centimeters proximal to the distal insertion. You'll note in this image that there's this area that becomes very much thickened around here, and it has mixed tissue changes and signal noticed notably in these areas. These are called mucoid changes, and this heterogeneous signal is suggestive or indicative of degenerative changes. Under ultrasound, we have on this bottom left image, we have an unaffected and an affected side. You'll notice that on this left-hand image, there is a thin band of a Achilles tendon where the tendon is normal in size and width, and on this right-hand side, it is much thicker. On this far right picture, we have the Achilles tendon in short axis, and in this image, it actually looks quite normal. This is what tendinopathy looks like under ultrasound. This is likely a review for most of you, but we'll go through this briefly. The images on top, A and B, demonstrate the long and short axis of the Achilles tendon that are normal in architecture. On the bottom, C and D, you'll notice a few things. Namely, we have the same widening and thickening of the Achilles tendon that was similar to what we saw on ultrasound. We also have where parts of it, for instance, the deep areas, continue to maintain at least some semblance of this fibular pattern, whereas this area superficially has sort of lost that. And you'll notice that this area not only has lost that, but it's gotten thickened. And we can compare that to what it looks like on the short axis. Again, you'll have this area on the bottom right that sort of maintains the normal architecture of the Achilles tendon, but the rest of it has become quite edematous. This area that looks sort of like a crescent has become edematous and lost its normal echotexture. Here's a summary slide for the treatment protocols for tendinopathy and their effects on short-term, long-term pain, as well as effects on recidivation. Now, on this left-hand side, you'll notice that we have therapies that go from progressively conservative to progressively invasive or even experimental. Now, rest and ice and NSAIDs and physiotherapy have been demonstrated to provide short-term benefit. Corticosteroid injections, namely, have been shown to be very good for short-term benefit in pain and possibly function, but not really give you a whole lot in terms of long-term benefit, and this is pretty consistent with what people see clinically. Now, one of the things, or two of the things that have been shown to really give people long-term benefit without being terribly invasive are eccentric training. You can look up Alfredson's protocol, as well as extracorporeal shockwave therapy. And you'll notice that these two, one of them is physical therapy and the other one is a modality, provide not only short-term pain relief, but long-term pain relief, and ideally help stimulate remodeling of that tissue such that people can have long-term benefit. Now, what are the other options that we see here? They talk about topical nitric oxide therapy, an injection of blood or PRP, sclerosing agents, stem cell or gene therapy. These are still in the process of being fully fleshed out, but I will go over some of the treatment studies that are in the literature. Now, what are the effects on pathologic tendons when exposed to platelet-rich plasma? This is a study where they had patients that were undergoing rotator cuff repair, and they retrieved some of those tendons. They were enzymatically isolated to obtain the tenocytes, and they placed them in a petri dish. They subjected these tenocytes to increasing concentrations of platelet-rich plasma, and they showed that the PRP had significant increase in cell proliferation at days 7 and 14 in a dose-dependent manner, meaning the higher the concentration of the platelet-rich plasma, the more cell proliferation we had of our tendon cells. Their conclusion was that PRP promotes cell proliferation and enhanced gene production, as well as the synthesis of tendon matrix and tenocytes from human rotator cuff tendons with degenerative tears. With that said, there are multiple studies that have looked at platelet-rich plasma, not only with injection into the tendon, but also comparing platelet-rich plasma to whole blood, as well as platelet-rich plasma to just needle fenestration. You should keep in mind that the mere act of needle fenestration induces a new injury in that pathologic tissue and can elicit by itself some level of healing. There are studies that are both positive and negative, and they have looked at tissues and joints throughout the body. We're going to just focus on a few of them because we do not have time to cover them all. The tennis elbow, the common extensor tendon, this is the poster child for regenerative medicine. Probably the most well-performed studies throughout the world have been looking at tennis elbow. Here is a study that compared patients with lateral epicondylitis or tennis elbow, which were patients were randomized to ACP, which is autologous conditioned plasma, compared to betamethasone and lignocaine. The primary outcome measure for the study was the DASH, the Disability Arm, Shoulder, Hand score, and they followed people up to 12 months. The interesting thing that you'll see in the study was that at 6 weeks and 6 months, the DASH score was actually better in the corticosteroid and local anesthetic group, but once they followed people up to 1 year, the DASH scores were significantly better. This drives home that these procedures, although they might have some early benefits, the regeneration or the remodeling of the tissue takes time, and that the full benefits may not be fully manifested for quite some time. This is the PureBoom study, which in this publication followed these patients out to 1 year, but subsequently they published the follow-up study where they followed them up to 2 years. Now this is a double-blind randomized controlled trial where they compared patients who received platelet-rich plasma versus corticosteroid injection. Again, the Disability Arm, Shoulder, Hand score. The DASH, the higher the DASH score, the worse off you are. You'll notice on the left-hand side of the screen, on the y-axis, it goes from 0 to 100, and on the x-axis, it goes from 0 to 52 weeks. What we have on the dark green line is on the graph is the representation for the corticosteroid, and the light green arm is the PRP. You'll notice that the PRP arm has a less downward slope trajectory, slightly less compared to the corticosteroid arm, meaning they did not improve quite as quickly, but they still improved compared to the corticosteroid arm. But there's a crossover of the two arms of the study at approximately week 12, and you notice at the 52-week endpoint for the study that the steroid arm meandered back towards the baseline with a mean delta represented by the double-headed purple arrows. The mean delta is quite small, whereas in the PRP arm there's a significant change in the Disability Arm, Shoulder, Hand score between baseline and 52 weeks. This is very similar to what has been found for their pain scores as well. Again, the corticosteroid arm is the light gray, whereas the PRP arm is the black boxes. And you'll notice again, approximately the 9-10 week mark, there's a crossover of the two arms, and the steroid arm meanders back towards baseline. Their mean delta for their VAS score is pretty much going from a 7 to maybe a 5, whereas for the PRP arm, they're going from approximately a 7 down to a 2. This is the 2-year follow-up for that study. Again, they looked at the patients, and they showed, importantly, that the steroid arm returned back towards baseline levels of pain and disability, while those of the PRP group significantly improved, and they were long-lasting benefits. This further supports the idea that there is some type of regeneration or healing of the tissue, and that you have remodeling that promotes long-lasting benefit. Here are some samples of some positive studies looking at PRP. You'll notice that they compare PRP to corticosteroids and follow people up to 12 weeks and then 24 weeks, and even some of these studies up to 2 years. There are studies that have compared people only up to 8 weeks. Here's where one study they compared PRP to whole blood, and they showed that there was no difference up to 8 weeks, but there is a likelihood that there might be some divergence in the outcomes, where there's a trend that the PRP arm might be superior. Again, if you compare this to the PRP versus steroid arms, like in the PureBoom study, it took some time for the divergence to really occur. Because you should keep in mind that whole blood is not a placebo, and it actually has the platelets within it as well. Here are some negative studies looking at tendinopathy and treating the lateral epicondyle, and you have PRP versus steroid versus saline, only up to 3 months, which is 12 weeks. PRP versus whole blood up to 6 months. PRP versus whole blood up to 6 months. Again, the whole blood is not is an active control, and so it does have biological effect. I had mentioned previously that dry needling itself in the Mishra study has been shown to have benefit as well. Moving on to ligaments. Ligaments are also avascular structures. They connect bone to bone. They are tight and compact and very dense. There have been multiple studies looking at how the PRP may affect the maturation of grafts when people are undergoing ligamentous repair. And in general, it has been believed that the addition of blood products, including PRP, are going to reduce the failure rate for your surgical grafts and improve graft maturation. Here's a study that was published in 2016 that looked at the effects of PRP on patients with plantar fasciitis. They had 32 patients with plantar fascia that were randomized to PRP versus steroid and lidocaine. They looked at the VAS as well as the Rolls and Modley score, which is a ability score, as opposed to the DASH, which is a disability score. And they followed these people up to 6 months. This is very similar to the outcomes from the PureBoom study. You find that when they look at the pain scores at baseline, they are very similar, and approximately at the 12-week mark, in 13, 14-week mark in this study, you have crossover of the two arms of the study, whereas the steroid arm, the effects start to wear off, as compared to the PRP arm, where you have longer lasting benefit. Looking at the Rolls and Modley ability score, this is where the higher your ability, the higher your score. And the same idea, the PRP arm has continued improvement up to the 6-month mark, whereas the steroid arm of the study has crossover at approximately the 14 or 15-week mark and meanders back to baseline. What is the take-home message here? Well, I think that there is strong evidence for the treatment of tendinopathy. This evidence is better than upper extremity as opposed to lower extremity. There's emerging evidence for treatment of ligamentous injuries, but this is only for select indications because many things have yet to be studied. I think that there's strong level 1 evidence that shows that PRP is superior to hyaluronic acid and corticosteroids for the treatment of large joints, specifically the knee. This is a little bit like preaching to the choir, but I like to throw this out there because I think it's important to utilize image guidance for your procedures and for diagnostic purposes. And this brings us back to a famous quote that I really appreciate, which is that you don't see what you do not know, and because of that, you'll never be able to fix what you do not see. If you look at this image on the top left, you'll notice that there are 2 people operating this procedure, and there's definitely not going to be some union between the 2 of them. Thank you for listening to my talk. If you'd like to find out more about the things that I do, you can follow me on Instagram at RegenMedDoctor. I'd like to take a brief moment and thank my good friends Sadiq Bayani and Amar Salti for allowing me to be a part of their prestigious meeting. I hope to see you all soon in a COVID-free world. Be well.